I do that. But this is about where we left off yesterday. And when I talked, and I don't know, like I said, how much you went, I know you touched on the heart in terminology, but the whole point of the heart, when you have you have four chambers, and then you have the vessels, and you have the major vessels that come into the heart, but you have the major vessels that take blood away from the heart. The way that these move in one direction is there are one-way valves, okay? Now, this picture is, what I want to mention is there is an error in the picture, and I typed in, normally the anatomy notes, I don't have a lot of stuff underneath the picture as notes because I verbally say it, but I couldn't edit the picture change. So remember, blue always pertains to the right side of the heart, and that is deoxygenated blood. So the right valve is actually the tricuspid valve, okay? But it is supposed to be on the side with the blue. On the left, which is the red side of the heart, is the mitral valve. It also goes by the left atrioventricular valve. But if you think about it, the valve separates the atria and the ventricle. So atrioventricular valve is the valve that prevents backflow. So and hopefully everybody's watching me right now because I'm going to give you just a little example. So the atria are supposed to contract first. When they squeeze, the blood goes down to the ventricle, and the valve separates the atria and ventricle. Think of it like a gate. Like if you had a gate that opened into your yard, okay, the valves are they're called one-way valves because they're supposed to open one way. So they open down. So when the atria up here contracts to the ventricle, the valve opens and it's supposed to snap shut. Now, it's not supposed to open up backwards, because what will happen is when the ventricle contracts, if this is open, blood can go backwards back up into the atria. So it's supposed to be atria, valve opens, blood goes down, then what's going to happen is the ventricle is going to contract, and if you look right here, there is a valve called the pulmonary valve. Some people call it semilunar. The shape is because it's a moon shape, a half moon shape, or a semi-lunar, semi-moon. So the lunar is named for the shape of the valve. But what happens is when the ventricle contracts, that valve will open this way and let blood out. But when the heart is in relaxation, that valve will close because we don't want blood that's sitting in that vessel to come back down to the ventricle. And then on the left side of the heart, there is a valve, and it's behind here, but it's called the aortic valve, and it opens so that blood can go out the aorta. But I'm going to be talking a little bit about the heart sounds. When a dog has a murmur, if you ever hear what's called a heart murmur, and sometimes they call it their heart sounds like a washing machine. What is happening sometimes is that valve isn't opening all the way, or it isn't closing all the way. It might be like your gate is broken. And what happens is then blood can go backwards, and it's like a swirling effect. And the swooshing that you hear is what you're hearing in a murmur. So typically a murmur means there's some type of valvular disease or a disease of those valves. And so I'm going to get into that, but I just wanted to explain is they are called one-way valves because blood should only go from the atria to the ventricle out the vessel. It should never come backwards. And that's when it snaps shut. The other thing that you'll see in the heart are these things down here. And actually, when we open the heart in dissection, you can actually find these and see these. They're called chordae tendineae. Or think about cords. What they do is they will anchor that valve. And so what they're supposed to do is as the valve opens and it shuts, it's kind of like a tension cord. So it prevents the valves from just going like this in the wind. So it'll go like open, shut, and that cord will prevent it. So if someone says, oh, you're pulling on my heartstrings, The chordae tendineae are the heartstrings. But I do want you to know, like on a test, I wouldn't say, those are the heartstrings. Those are the chordae tendineae, but they anchor the valves in the heart. That's the job of the chordae tendineae. Think of it like if you had a gate in your yard and it opened one way and it had a little spring that prevented your gate from just like opening. It's like an anchor for your gate. That's what a valve is, and that's what the chordae tendineae do, so they don't just go back and forth. Now, this is a weird term. There is no bone in the heart. If we talk about what's called the skeleton of the heart, if you think about where the heart lies, it lies in the middle of the lungs. And there are very dense fibrous rings that anchor the aorta, that anchor the pulmonary artery and the connection to the lungs. And that is very dense. And then other connective tissue that we find in the heart, that atrioventricular septum, that divider, okay, it looks like muscle. There is muscle along that divider, okay? So the septum provides, a place for the muscles to attach, but it also creates that dividing line. And it's made of very, very dense connective tissue. It's very, very strong. So it anchors the valves. It gives attachment for the pericardium. It also provides as an insulator or an electrical insulation. So hang on one second, someone's messaging. Someone's trying to get in. Okay, so it's an electrical insulator, a supportive mechanism within the heart, and it's very dense connective tissue. Similar to the pericardium is very similar construction, but the pericardium is on the outside. So this is within the heart and anchors the heart in the chest. Now, what I talked about yesterday, or I mentioned this briefly, is the coronary arteries. How does the heart get its blood? The heart is a muscle. Every muscle needs oxygenated blood. So if you look up here, now this is what's always confusing about heart pictures. There's all these are all the pulmonary arteries in the aorta that are leaving the heart. But what happens is the coronary arteries are a tiny little branch off the aorta. So if this is the aorta up here, okay, there's going to be do you see this little red branch right here? It's kind of wrapping around the heart. And then these tiny little vessels. So imagine if the aorta was like you get off an exit ramp and then you make that super sharp right and you kind of like come around. It's like the coronary artery is a little branch, and then it comes in with little arterioles and capillaries, and it goes into the heart muscle. And that is how the heart gets its blood, is through the coronary artery. But they are on the outside of the heart, not on the inside, not inside the chambers. The coronary veins, then when the heart muscle is done using the oxygenated blood, the deoxygenated blood that has to go back goes into these blue vessels, the coronary veins, and they dump right into the right atrium, because the right atrium is receiving the deoxygenated blood from circulation. So it's very simple for those vessels to just dump right into the right atrium, because it's going to go right atrium, right ventricle, and then to the lungs. When this becomes important, and what I want you to realize, when an animal's heart is beating at relaxation, okay, when they squeeze, they are pumping blood out. When the heart is in relaxation, it dilates. That is when the heart muscle receives its blood. Okay, think about a kitchen sponge. If you were like washing dishes and you squeeze your sponge and you squeeze all the water out, when you relax the sponge and put it under water, it sucks up all the water. Think about the myocardium like a sponge. When the heart is squeezing and it's pushing blood out, the heart has to come back into relaxation to fill. The chambers inside fill, and the coronary arteries perfuse the heart on the outside. When this becomes important, and I hammer this home in anesthesia, is when we think about an animal's heart rate, okay? When an animal is sleeping and at rest, I'll give you an example, a Great Dane. So a Great Dane is an extremely large breed, okay? They have a very big heart. A Great Dane sleeping probably has a heart rate below 50, maybe in the 40s. My boxer, I took it one night when he was sleeping, and he was like 52 beats a minute. And he's only like 60 pounds. So now, when an animal's heart speeds up, obviously because it, maybe they're running or playing or whatever, then they're going to be pumping out more blood. But what I'm talking about is if we have animals that have too high of a heart rate for themselves, then what happens is the heart is beating really fast. When did I tell you that the heart fills with blood, and when does the muscle perfuse itself? It's when it's in relaxation. The faster that my heart beats, okay, the less time it's filling up, or it's in relaxation. And what that can do is that can affect the oxygenation of the heart muscle, because the heart needs to spend enough time in relaxation for the heart muscle to get its blood. So as an anesthetist, I get concerned when I have animals that have heart rates that are maybe very high outside their normal range, because I know it's affecting their ventricular filling, and it's also affecting something called myocardial oxygen consumption. I'm gonna go ahead and type that because so all I typed on the chat screen was myocardial oxygen consumption is decreased the faster the heart is beating. The faster that this is happening, the less time it spends in relaxation. And when it's in relaxation, that is when it perfuses. Perfusion is oxygenated blood penetrating or reaching the cells in the tissues. That is what perfusion is. It is very important. So what I have to look at, and why I stress heart rate in emergency medicine, in anesthesia, when an animal presents extremely tachycardic, which is their heart rate is too high, I know that that's being affected. And that's what leads to dogs having arrhythmias or abnormal heartbeats. And it also can affect how much blood is being pumped out of the heart, and it can affect blood pressure because it's all interconnected. So I'm going to build on this, but it's important because to understand when those vessels fill up the heart muscle, and they are located on the outside of the heart. Again, when the heart is squeezing, it's pushing blood out, that muscle is contracted. When that muscle relaxes, then those vessels can fill that heart muscle with blood, because it's a muscle. And even though it's full of blood on the inside, that's not where it gets its oxygenated blood. Okay. And remember, anytime on a picture here you see a red vessel, that is an artery. And anytime you see blue, that's a vein. So oxygenated blood versus deoxygenated blood. Okay, another important concept to understand, and I asked this on a test, and I think everybody got it right, but nerve supply to the heart. The SA node, which is called the sinoatrial node, is the pacemaker, and that's what sets the heartbeat. When it fires, think of it like a little electrical shock. It starts the wave of contraction. Now, nerve supply is not essential for the pacemaker to work. The pacemaker is going to initiate a heartbeat no matter what. Now, The nerve supply, all I want you to understand is the nerve supply is not essential for the heart to function. But if an animal is in fight and flight, okay, remember it's like that stress response, they're ready to go. And obviously, you know, if someone scares you, you sometimes feel like your heart's beating out of your chest. It's beating so fast, you're breathing harder. External stimulation, external motor stimulation, or sympathetic stimulation is going to increase oxygen demand. Okay. The body is going to be like, dude, we need more oxygen to our muscles. I'm about to run. And then the body goes, okay, I'll give you more oxygen to your muscles. My heart is going to beat faster and harder. It's not that there was a nerve that went to the heart to do this. It's the heart is responding to a need the body has. The SA node will fire faster and it will beat stronger. But as long as you understand, there's not a nerve that went and did that. It was just the heart is responding to the needs of the body. I mean, they're all working together. If you remember week 1, I talked about homeostasis. Homeostasis is all the body systems working together to create normal body function. So if the nervous system amps up the body, the heart's like, I'm going to help you out. I'm going to beat harder. Okay. But it's like a natural response to the nervous system. Again, not a nerve that's going in there and doing this directly. Now, this is a good picture because it explains this whole figure 8 system. So it's just a different image. You will not have to label this, but what it's going to help you understand is anytime, like I'm pointing at the picture right now, anything that looks like a net, all those things that look kind of like lacy net, those are the capillaries. Okay. And if you notice inside every organ, the lungs, this is the liver, intestines, here's a kidney, here's a systemic or like a muscle bed. In every area, they're red and blue together. So I want you to follow my arrow. Okay. You guys are going to have to trace blood flow through the heart. You're going to have to tell me all the names of the parts that it goes through. I'm going to give you an example. I always start with the aorta. Okay, because that's the first place oxygenated blood leaves the heart. For me, that works for me. So I'm going to point at the aorta right up here. So what I would write is I would put, all I'm going to have you guys do is write the name of the part and an arrow, then the next part and an arrow. So I would be like, let me get my arrow, aorta, and then I'm going to say, let's do the kidney. Okay, so it goes aorta, renal artery. There's tiny little one here that's called a renal arteriole. So an artery goes to an arteriole. I'm going to talk about that. Then it goes to a renal capillary. At the capillary level, I would then write O2 for CO2. You're giving O2, and then the blood is going to pick up CO2. Then it's going to go renal venule. So after a renal capillary, and a renal capillary represents oxygen and deoxygenated blood. But when it goes to the body, it drops off oxygen first, then it picks up CO2. And then it goes to right here, this little blue thing is a renal venule. Okay, this is the renal vein. The renal vein is going to branch into this big mama here called the vena cava. The aorta is the mama artery. The vena cava is the mama vein. Okay, so it's going to go renal vein, vena cava. The vena cava is going to come in here and dump. It's going to do right atrium. I'm going to write all this out for you guys too, so don't worry. Right atrium, where's my arrow? Tricuspid valve, right ventricle. Now after the right ventricle, it's going to go out these two vessels here and split because there's two sides to the lungs. This is the pulmonary artery. Pulmonary artery is going to go to the lungs. Now see how it's blue first? Because the veins have deoxygenated blood. So when I go to pulmonary artery, pulmonary arterial, pulmonary capillary. Then I'm going to say CO2 for O2, because in the lungs, it's the opposite. It drops off CO2 and it picks up oxygen. Then it comes to a pulmonary arterial, a pulmonary artery, pulmonary vein, I'm sorry. So it goes pulmonary venule, pulmonary vein, left atrium, whoopsie shit. Oh, sorry, oops. Mitral valve, left ventricle, aorta. Do you see how I've completed the cycle? When you write it out, you have to get me back to where you started, wherever you start. I used to make everybody start at the aorta, and then some students are like, well, I like to start at the right ventricle. I'm like, if you can get me back to where you started, I can follow it. I don't care. Let me give you another analogy of this picture, and hopefully I've not lost everybody. Okay, this will make sense, I promise. Think about the highway, okay? 465. 465 is the major highway that circles Indianapolis, okay? If I'm on the highway and you have that major 465, the big one, and then all of a sudden I go, you know what? I'm going to hit 465 east. Okay, that's kind of like the renal artery. And then, oh, I'm going to get off on Emerson. Oh, and then I'm going to get off at 10th Street. Oh, and then I'm going to get off of, this road that turns into my neighborhood. And then I'm going to go into my driveway. Do you see how I went from a big road to the smallest road, which is my driveway? At my driveway, I drop off my oxygen and I pick up CO2. Well, now I got to go back to work. So I'm going to go from my driveway, the road in my neighborhood, to 10th Street, to Emerson, to 465 East, to 465. Do you see now when I leave my house, I go from Little Road, which is the driveway, to the biggest road. If you think about the vessels like a road map, when I was in, when I was at Purdue, and if you guys haven't figured out yet, I'm strange. I pretended that the vessels were a road and the car was carrying oxygen. Okay, and I drove through, and the names of the roads were the names of my vessels. When I got to the capillary, I dropped off my buddy oxygen, and then this guy CO2 comes out and he says, well, hey, you're going back. Can I hitch a ride? I'm like, fine, jump in the car. CO2 gets in now, and CO2, we go back on that same road, and I go back, and then when I get to the lungs, they're like, hey, this is where I need to be dropped off at. And then there's an oxygen buddy, and they're like, hey, are you going back? And I'm like, fine, jump in the car. Oxygen goes. Do you see what I'm doing? So whenever you get to the tissues, arterial blood, their job is to drop off oxygen to tissues. But they're not going to do that out of the aorta or the renal artery. They're going to have to get to a capillary bed, and it's going to branch. So the aorta is like a massive highway, and getting to your driveway ultimately is the capillary. And that's where you're going to drop off. You're going to exchange people. You're going to exchange oxygen and CO2. And then when you get to the lungs, you're doing essentially the same thing. You're going to the lungs. When you get to a pulmonary capillary, which is the tiniest vessel, except you're doing the opposite thing. You're dropping off the CO2 because the lungs are going to exhale. That's how the body gets rid of CO2. It has to be transported from the tissues, and it has to be brought to the lungs so it can be exhaled. Hang on. Sorry. Okay. So this is all that I'm explaining and sometimes that may sound strange, but the analogy is that the heart's job is to pump the blood. The blood's job is to carry oxygen and nutrients to tissues, but the blood also transports wastes. Like when we talk about the digestive system, I'll get into that. But the tissues create carbon dioxide, and it's part of a byproduct of metabolism. So that has to have a way to leave the body. So because the blood is going back to the lungs will pick up that CO2 and exhale it. Now, when you guys trace the blood, you're always going to start from somewhere in the heart or like the aorta. You should know your vessels are going to have to go from big to little, but when you go back to the heart, you're going to go little to big. Okay? Blood does not go from the kidney right here right to the vena cava. It's going to have to leave a branch. Okay? Here's a systemic branch. The back legs have, if the back legs are down here, which can't, you know, okay. The back legs would be here. The femoral veins would come from the back legs and join the vena cava, and then that's where it goes. So everything branches together. I will give you all the names and how I want it wrote out, and we're going to talk about it in the slide in a second. So I will get into that. Are there any questions on that, or type something if you're not making sense? I had to come up with really weird analogies when I was in school because I wasn't this like naturally memorizing kind of person. I had to be like, if I could come up with something goofy or something strange, that's how I remembered it. So I always try to share it if that makes sense. But if you think about your driveway, or like when I was talking about the pipes of a water company. When the pipes leave the Indianapolis Water Company, they're very, very large. But then they're going to have to subdivide and carry water to every business and every house. The pipe at your house is not nearly as big as the pipe coming from the water company, because it's going to go from big to little. And then when our water goes back, it's going to go little to big. So it's the same, it's all interconnected. The heart and the vessels are all connected to create this transit system. And then the job of the blood, obviously the main one is oxygen delivery, nutrients, and then it's also transport waste. So just we'll keep talking about that concept. Now, there are, the homework sheet, no, I'm sorry, the study guide I sent you, which was not homework, there is, I think in the one I sent you doesn't have this written on it. I talk about the difference between mechanical and electrical activity. Let me type this real quick. So that's a question that I did not type on that study guide. So I just typed, you need to understand the difference between electrical activity and mechanical activity of the heart. Now, if you think about something mechanical, when the heart is beating, when you hear a heartbeat, the heart is beating. It is pumping. Think about the heart being a mechanical pump. Now, there is an electrical side to the heart. There is an electrical conduction system, and I do want you to know the order. This is not a picture you have to label. This is just explaining the order. Okay, now follow me here. When the think about, these are a series of fibers that conduct electrical impulses in the heart. It starts at the SA node, which happens to stand for sinoatrial. And wow, it's found in the atrium. It's not called the sinoventricle node. It's called the sinoatrial node. So the SA node is what starts the fire. When it fires, it's going to travel down this branch, and then it's going to go through. Do you see how these are like little nodes? They're kind of like little switches. It has to go through here to here to here to here. The AV node is found in between the atria and the ventricles. That's why it's called the AV node. So I go a sinoatrial, atrioventricular. After the impulse reaches, now when the SA node fires, we're going to get this atrial contraction. When it moves down to here, it's going to send a signal from the AV node. If you look at the little chart, it goes sinoatrial. That sends the impulse to the right and left atria. They contract. Then the signal goes through the AV node. The AV node is going to go through the right and left bundle branches. Now think of these like little things down here as branches. Those fibers, they're actually called Purkinje fibers. It's right here on the chart. These little branches, these red branches are Purkinje fibers. They are embedded in the muscles of the ventricles. After the signal goes through this switch, the AV node, it travels through the Purkinje fibers through the right and left bundle branches, and that's what causes the ventricles to contract. This is how the heart doesn't all squeeze at once. If your heart just squeezed all at once, blood would really not go anywhere. It needs to be a coordinated contraction. So when this fires, it will then cause this to fire, which will then cause these to fire. But do you see the atria were fired first? So the atria contract, and then the ventricles contract. Does everybody understand that? So the order here, and I'll just type it briefly because I know there's lots of words on here, but SA node to AV node to the other, so it goes SA node, AV node, Purkinje fibers, which are called the bundle of His. If you look here, right and left bundle branches are the bundle of His. But what this causes is the SA node will squeeze, or the atria will squeeze, then the ventricle squeezes. As long as the electrical system follows this wave. Now, have you heard of an EKG? Or when someone gets an ECG or an EKG, you see that beep, beep, beep on a screen, you get a tracing. I'm going to talk about that in a minute, or it's later in this PowerPoint. One important thing to understand is almost every anesthetized animal has an EKG on it. And what it is doing, it is giving you a graphic representation of electrical activity of the heart. If you have electrical activity of the heart, you can assume that your heart is beating. But every time you see a little beep, beep, beep on a screen, every time you see that, you better hear a heartbeat. I'm going to type something here. Okay, there's two conditions that I caution students on. One is called well, they mean the same thing. Electromechanical dissociation, which is known as EMD, or PEA, pulseless electrical activity. I'm going to tell you when we've seen this, and this can happen on an animal. It can be rare. We had a dog when I was at Purdue, and it was a pretty advanced surgery. It was a really bad case. The owner had given us permission, if it was very bad, to euthanize the dog during surgery. Unfortunately, it was terrible. It was just a really bad case. So we called the owner, unfortunately confirmed, and we had a bunch of students in the room. I had tech students, I had veterinary students, I had the anesthesiologist, and I had the student listening to the heart. And I told her, I said, I want you to put your head down. I said, do not look at the ECG. I said, put your head down. We're going to give the euthanasia solution. I said, raise your hand when you cannot hear a heartbeat anymore. And I said, the rest of you in the room, watch the EKG. So we push the euthanasia solution, and in about 20, 30 seconds, she raises her hand because she cannot hear a heartbeat. The ECG ran normal for 10 minutes. No change in the EKG. It looked like a normal EKG. Clinically, that animal is dead when that heart is not beating. But if you were just looking at the ECG to see if your patient was alive and your ECG kept going, you would think your patient's alive. Do you see what I'm saying? And you have about 5 minutes to resuscitate a patient once they code. In veterinary medicine, we are not as successful as in human medicine. In human medicine, you might try for like an hour. In veterinary medicine, it's a little bit different. You have probably 5-7 minutes to get, if you looked at that ECG and waited till it looked abnormal, your patient had been clinically dead for 10 minutes. You're not going to get that patient back. And I saw this happen on a case that was pretty bad. We got the dog back, but let me give you a scenario too. Scenario number 2. This is when I taught at the school the first time. I taught at IBC. This is my 3-year anniversary back teaching full time, but I taught here about 10, 12 years ago. And I was in surgery rotation, and the students had a little ECG. There was 3 students on a cat, and I was watching them, and they were all staring at the ECG. They'd kind of look at the cat. So under the table, I started wiggling the electrical cord, or I started wiggling the ECG. And then they're like, Miss Landeros, wait, oh my God, Miss Landeros, something's wrong. The cat, and I go, oh my God, is your cat dying? Or is your teacher wiggling the cord under the table? And then they stopped a minute, and they looked at me, and they looked at the cat, and they go, wait a minute. They're like, you're really mean. And I go, you know what every one of you did? I said, you looked at the ECG and you freaked out. Did anybody pick up a stethoscope and put a stethoscope on the cat's chest? Did anybody feel for a pulse? Did anybody touch the cat to verify that the ECG was accurate? Are you picking up what I'm putting down? My point is, and I can only see Sean's face, so I don't know if everyone's listening, but my point is, and someone said, Miss Landeros, you hate ECGs. No. ECGs are a fabulous tool. ECGs should be monitored, but it is not the only thing to be looking at, because what I've tried to tell people, they can be highly inaccurate. I was helping a student in surgery rotation a couple terms ago, and we were getting a lot of interference, and she kept staring at the ECG, and the heart rate number kept jumping. It went from like 40 to 210 to 110 to 50 and she's like, what on earth? She's like, I can't get a heart rate on this cat. I said, put your stethoscope in your ears. And I said, listen to the heart. And the heart was going boom, boom, boom. And she goes, oh, that's like not doing anything. I said, well, look at what they were scrubbing the cat for surgery. They were bumping the cords. And so she's looking at that number on the ECG, and she's looking at the ECG, and it's like, I said, put your stethoscope in. And I said, that's going to tell you what your heart is doing. Ultimately, your heart pumping is the most important piece of the puzzle. An ECG is fantastic, but you always have to listen to your heart and make sure it's doing what the ECG says it's doing. And that's just my take-home message is, what is an ECG doing? It's telling you that this electrical system is doing what it's supposed to be doing. That's what an ECG tells you. Now, when you get an abnormal, in Tech 4, Animal Tech 4, you guys do ECGs. You go in depth about arrhythmias. Arrhythmias is an abnormal tracing or an abnormal ECG. Different arrhythmias mean different things. Now, if this electrical system isn't working properly, your atria and ventricles aren't going to work. Now, I know a lot of you guys like to watch, what's that medical show? Grey's Anatomy? I haven't watched it in like forever, but everyone that watches any kind of medical show, I should say, When you get the squiggly lines on the ECG, and that's called fibrillation, that's called ventricular fibrillation. And then they get the paddles and go clear, chunk. What they're trying to do, this little thing, is all of this electrical activity is like not working. It's like misfiring. By shocking, you're trying to get this shocked back into that normal electrical rhythm. That's what a paddles do. Yes, that's very true. Makes you cry a lot. But everybody, I think when people go clear and they hear that, it's an electrical shock to the heart, and the job it's trying to do is to get this, it's what's happening is this firing of electrical activity is disorganized. It's not following its normal pattern. That's a good question, Madison. I would say on people, any ECG could be faulty, but you get better contact. They put those little sticky pads usually on people. We are going through fur, and then we clip it on the fur. Now, what you usually do during surgery is we wet it with alcohol. So we clip it on the fur and then we wet them down. Some people put a little bit of gel and alcohol. I've seen ECGs start to get weird during surgery, and it's because the alcohol dried out. And so now you have a clip-on fur. So one of the first things I do is I go under the table and I wet the leads. Well, after I listen to the heart and I make sure the heart's okay. So I would say you can I've had good ECGs on animals, but the contact is an issue. Also, yes, Alicia, that's exactly correct. When I say mechanical activity, that is the heart physically squeezing and pumping blood. Electrical activity is the conduction system that is trying to trigger the muscles to contract to pump. So it's kind of like the electrical system triggers the pump pumps the blood. Does that make better sense? And what I've tried to tell you, and I never say this to scare anybody, is to say that in cases, and it's not common, electrical mechanical disassociation means just that. Electrical and mechanical activity disassociate. And this means electrical activity can look normal and the heart is not pumping. If the heart does not pump, your patient is dead. So this can look at pretty, I don't care. This is what I care about. Does that make sense? So that's why, and the problem is students sometimes get starry-eyed and look at the monitor and it's all pretty. And when I worked at Purdue with the anesthesiologist, he would come into rooms, and this could be vet students or tech students. He would watch the students, and if he saw them watching the monitor and they just kept writing everything from the monitor, he'd walk over and turn off the monitor. And he goes, now monitor your patient. Well, you have a stethoscope, you have hands, you have eyes. You can monitor a patient under anesthesia without an ECG. But if he caught them staring, yeah. Yes, Tia, you can, that's what that term that I typed in the chat, it says electrical mechanical disassociation. That's where electrical activity persists and mechanical activity stops. So the patient that we euthanized, the heart stopped within 30 seconds because the student couldn't hear a heartbeat. She lost the heartbeat. That means the patient is clinically passed away, but everybody that was watching the EKG, it looked normal. It could be related to that. Sometimes it's related that electrical activity is still moving, even though if blood's not pumping, you don't get oxygen to tissues. Eventually that lack of oxygen is going to affect that node. So it may be that there's a residual oxygen left over. And I don't want you guys to think this happens all the time. I just introduced this because I want you to understand the difference of what the electrical activity does and what the mechanical activity does. And the mechanical activity is the most important because that is the physical act of blood pumping. Does that make sense? Or Madison, does that answer your question? Like I said, it could be not as much of the brain, but residual oxygen left over, and it's still doing its job. Some important concepts are coming up. So I know it's 9:12 and you guys are getting ready to go to your Breeds ClinMed. Does anybody have any questions? And I can unmute people for a second here. So the biggest thing to understand is electrical activity. Okay, when you turn on a light switch, a signal is fired, it should make it to the light bulb turns on. When the SA node fires, it's like a switch, and that electrical signal should trigger the muscles of the atria to contract, and it should trigger the muscles of the ventricles to contract. That's the normal electrical flow. Now, when the ventricles and atria actually contract, that's the mechanical pumping of the heart. But it started technically by the electrical system firing. So I just want you to know the difference between the two. Are there any other questions that I can answer about that? And I typed some stuff of this in the chat, so hopefully if you're writing some notes down, you wrote down a few of these things. Okay. Well, as long as you typed here when you're here, I'll go ahead and end this. Be looking for the email to come a little bit later today with the picture and this video from today's lecture. And oh yeah, as long as you've typed a comment too, like Madison, you made a comment, I count that as here, so that's fine. Okay, well, I'm gonna let you guys be free to go.